Vanakkam. Shoulder problems in children affected by birth brachial plexus palsy. Why we never discussed shoulder problems in adults affected by brachial plexus injuries? That is because the only problem that the adults have with the shoulder in brachial plexus injury is weakness. Whereas in children affected by birth brachial plexus palsy, there are three issues to be dealt with. What are these three issues and how do we diagnose and assess these issues? These are exactly the points that we are going to discuss in this video. Before we talk about the management of the shoulder problems in birth brachial plexus palsy, we need to understand that even children with the mildest residual plexopathy will have some limitation of shoulder motion, and only infants who recover anti-gravity bicep strength in the first 4 to 6 weeks of life will have no asymmetry of their shoulder movement even on careful examination. So what is it that can happen to the shoulder in birth brachial plexus palsy? Three things can happen: weakness, contracture, and joint deformity, otherwise called glenohumeral deformity or dysplasia. Weakness of movements of the shoulder could be mainly of shoulder abduction and shoulder external rotation. And when we talk about contracture of the shoulder, we are talking about the decreased range of movements of the shoulder joint due to changes in non-skeletal tissues. A study showed that 56% of all birth brachial plexus palsy patients develop shoulder contractures, and that once established, shoulder contractures do not resolve spontaneously. On the other hand, 33% of all birth brachial plexus palsy patients and as many as 58 to 74% of patients examined with shoulder MRI had glenohumeral dysplasia of some degree. Weakness of the shoulder leads to contracture, and contracture further intensifies the weakness. Both these lead to glenohumeral dysplasia or changes in the shoulder joint. So basically, failure to maintain full passive range of motion of the shoulder joint leads to development of the glenohumeral deformity. Is it possible to prevent these three problems from occurring in the shoulder in the child affected by birth brachial plexus palsy? Yes, to a certain extent, in the form of correct therapy, appropriate splinting, appropriate use of botulinum toxin or Botox injections, and early surgical interventions during the period of infancy to get back the reinnervation of the denervated muscles around the shoulder. When these methods are inadequate or they fail, we get the problems in the shoulder. We shall now learn about the pathogenesis, the assessment and the management of all the problems that occur in the shoulder in birth brachial plexus palsy, namely weakness, contracture and glenohumeral dysplasia. When we talk about the pathogenesis of weakness of the shoulder, we are referring to weakness of shoulder abduction and weakness of shoulder external rotation. Weakness of shoulder abduction occurs in patients with upper trunk involvement, that is C5-6, who have a residual weakness of the supraspinatus and the other rotator cuff muscles and the deltoid. The supraspinatus may recover to a certain extent in some children, but the main problem is with the deltoid. There are two situations. The deltoid may be good, but there may be a strong co-contraction with the adductors between the four adductors and the two abductors of the shoulder joint, resulting in weak shoulder abduction, or the deltoid itself may be poorly innervated. When there is a weakness of external rotation of the shoulder, it can cause considerable functional consequences. External rotation of the shoulder is necessary to achieve above horizontal shoulder activity. Example, reaching the hand to the occiput or the forehead. We need to remember here that scapulothoracic winging can compensate for limited glenohumeral motion in all planes except external rotation. So the child will not be able to use the hand away from the body because there is a difficulty in placing and maintaining the hand at a desired location, and even when used at the child's side, it is done with the support from a desk or the ipsilateral leg or the arm of a chair. The pathogenesis of internal rotation contracture is a consequence of the weakness of one group of muscles. The adductors and internal rotators, the subscapularis, pectoralis major, latissimus dorsi and teres major are powerful, while the abductors like the supraspinatus and deltoid and the external rotators like the infraspinatus and teres minor are weak. So naturally, there is a tendency for positioning the shoulder always in adduction and internal rotation, leading to contracture. The passive range of external rotation of the shoulder must be measured with the shoulder kept adducted. It is defined as the angle between the sagittal plane and the position of the 90-degree flexed elbow after passive external rotation in adduction. Consequent to the contraction of the internal rotators, the subscapularis and the pectoralis major mainly, there occurs a contraction of the anterior ligaments of the glenohumeral joint, like the coracohumeral ligament and the glenohumeral ligaments. We may find some children with abduction and internal rotation contractures. Such a problem occurs when tendon transfers have been done without a joint reduction. These children will have excellent overhead function but marked limitations in the adduction and external rotation function. There is yet another type of contraction that can develop, the external rotation contracture or the abduction and external rotation contracture. This usually occurs after a surgical release of the internal rotators. In this small subset, patients are more functional, with the only complaint being winging of the scapula on attempts at internal rotation. Glenohumeral deformity is rare in this type of contracture, so though overhead function may be preserved, it may present with a cosmetic deformity only. The pathogenesis of the glenohumeral deformity has been extensively researched. The stages of the development of this deformity or dysplasia were described by Pearl and Edgerton. The normal glenohumeral joint is concentric, or the humeral head is centered on the glenoid cavity. When there is an internal rotation muscle imbalance, progressive flattening and retroversion of the humeral head occurs and the glenoid becomes flattened. The glenoid then gradually becomes biconcave, with the humeral head articulating with the posterior of the two concavities which were in the same plane. With time, the humerus dislocates posteriorly, creating a pseudoglenoid. This pseudoglenoid may be a minor pseudoglenoid where the angle of glenoid version is less than 30 degrees, moderate pseudoglenoid when the angle is between 30 and 60 degrees, and severe pseudoglenoid when the glenoid version angle is more than 60 degrees. In this position, the humeral head is almost articulating with fibrous tissue over cortical bone. Along with these changes in the joint, secondary adaptive changes occur, like overgrowth of the acromion and the lateral clavicle. Coracohumeral and coracoacromial ligaments become tight, further restricting external rotation. And as a consequence, the superior and inferior glenohumeral ligaments also become tightened. Having understood the pathogenesis of the changes occurring in the shoulder in birth brachial plexus palsy, we shall now try to understand how to assess the problem. This can be done mainly by clinical assessment and by imaging studies. The recovery of active muscle strength in infants, which can be graded by the MRC system, the Malay classification, or the HSC active movement scores, as has already been discussed in a previous video. When assessing the passive range of movement of the glenohumeral joint, we must remember to stabilize the scapula. Both internal and external rotation are performed in adduction and in 90 degrees of abduction while stabilizing the scapula against the thorax. After that, we need to assess three things, that is, the degree of scapular winging occurring posteriorly with passive internal rotation movements of the shoulder, rotation of the scapula superiorly with full adduction, that is the Patti's sign, and then movement of scapula into the axilla with full abduction and forward flexion. While evaluating the internal rotation contracture, the tightness of the subscapularis is evaluated by measuring the angle between the scapula and the humerus in abduction, again with scapular stabilization. Likewise, the pectoralis major, latissimus dorsi and teres major tightness can be assessed by palpation of the muscles with the shoulder abducted and externally rotated. Further evaluation of the glenohumeral dysplasia can be done by imaging studies using X-rays, ultrasonography, arthrograms and MRI. The role of X-rays in assessing the glenohumeral joint comes later in childhood and not in infancy. Here, progressive glenoid retroversion, flattening or absence of the glenoid cavity and hypoplasia of the humeral head with posterior subluxation can be visualized. Ultrasound can be used in infancy to evaluate the glenohumeral joint and the proximal part of the humerus. Sometimes rare proximal humeral physeal fractures and infantile glenohumeral joint dislocations can be detected by ultrasound. The advantage is that sedation is not required. The ultrasonographic findings that suggest shoulder subluxation are ultrasound measurement of alpha angle of more than 30 degrees and ossific nuclei of humerus lying behind the dorsal scapular line. We shall see more about this alpha angle soon. Arthrography can help in identifying the glenohumeral deformity as one of the four categories: concentric, flat, biconcave or pseudoglenoid. MRI is also useful, but we need to remember that in infants and young children, sedation is required. Waters et al. Presented a grading system from 1 to 7 to classify frequently seen patterns of deformity. There are two assessments that need to be done with an MRI: the percentage of humeral head anterior to the glenoid fossa, the PHHA, and secondly the angle of glenoid version. This is the type of MRI image from which the PHHA is calculated. If this is anterior and posterior, this represents the line of the scapula and the head of the humerus. The scapular axis is drawn which cuts the humeral head. The length of the head of the humerus anterior to this axis A and the length posterior to the axis B are calculated. The PHHA is now calculated by using the formula A divided by A plus B into 100. The glenoid version angle is calculated as follows. A line is drawn between the anterior and posterior aspect of the glenoid margin. The angle alpha formed between this line and the axis that we had marked earlier is measured. The value we get after subtracting 90 degrees from this alpha angle measurement is known as the glenoid version angle. If it gives a positive value, it indicates glenoid antiversion. If it gives a negative value, it indicates glenoid retroversion, which is characteristic in birth brachial plexus palsy. We must note that the above mentioned deformities of the shoulder can arise as early as within the first 3 months of life, and severity progresses with age. Changes also occur in the scapula, which has been termed as scapular hypoplasia, elevation and rotation. The total area of the hypoplastic scapula averages 14% less than the contralateral scapula and correlates with the severity of the deformity. The deformity has been classified into 4 grades. So far in this video, we have seen what happens to the shoulder in birth brachial plexus palsy, how it happens, and how it should be assessed. What remains is how to plan the management of these problems, and that will be dealt with in the next video. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about decision making in birth brachial plexus palsy and the surgical strategies that can be followed. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.